go. Oh, we are live in the studio here in beautiful Fort Lauderdale, Florida, and I have Dr. Anna Toker. How about some applause, Muriel? There we go. I love that. Okay. So, Dr. Toker,
Yes,
just
sir.
south of Dallas, Texas. Colorectal surgeon. You've been doing this for a while.
Hmm.
Couple decades.
A couple of decades. That is correct. I'm about to start my 20th year of practice coming up.
There we go. Congratulations to that. And so we are very fortunate to have her with us to talk about the ifs, ands, or buts, because that's really what you do. You are all focused about the butt, uh, which
Big
is
part of my practice.
it's a big part of your practice. Exactly. Uh,
Mm.
so I want to dive into some of the topics of women's health
Yes.
and their biggest issue, or many times, right, is
Mhm.
constipation.
Huge. Yep.
So, talk to me a little bit about women when they come in. So they're going to book an appointment because maybe it's a referral or it's a recommendation or it's a friend of a friend that says, hey, you need to go see Dr. Toker because she can get you
Maybe.
straightened
Yep.
out, hopefully, right? And get you on the
Yes.
path to success.
Yes. On the path to success. So some of these patients will be referred because they've already got an exam finding that seems surgical to the primary care doctor. And some of them are referred actually by the GI doctors who ironically don't want to hear this constipation issue. And that is kind of what they do. I can't explain that. So that's some of the referrals. And then some people just don't know where to turn. Some of them may think they have a hemorrhoid issue or they've got a bulge or a blockage. So the symptoms can vary.
Right?
I am a surgeon. So everything about the consultation in my mind is I'm looking for an operation to do. And sometimes we don't find anything to do. So it's a lot of talking, which is why a lot of, I'm sorry for my phone, which is why a lot of doctors don't want to have the conversation. So that's kind of how they get to me.
Yeah, it's a lot to unpack, right?
Yeah.
You've got
It's part of
years
the
of
human
usually like
condition. Yeah.
years of history that
Yeah. Intermittent constipation is part of the human condition. So, and no one wants, I don't want to hear about your constipation. Go take some fiber or something, so no one wants to really talk about it per se, but the patients, what, when they say the following, I think to myself, this person may or may not need my services as a surgeon. And the first is it's decades, right? Decades of I strain to use the restroom. And then it's also on a medication list, 5 or 6 different types of laxatives. Many times these patients will say, well, I had a bladder lift, I had a rectal repair, whatever the case. They've had other pelvic floor issues. So the second I've got a patient who walks in the door who has that kind of history, I get suspicious. And there are times where someone will come in and they're in their 20s. Now they've not had the pelvic floor repair stuff,
right.
but they'll say, as long as I can remember, I've had this issue. I'm on 6 laxatives a day. It takes me an hour to use the. If I don't have an hour to use the restroom, I just try to ignore, because it's an ordeal.
Right.
So that's kind of how I know it's reasonably serious, as opposed to someone who once every 3 months has to take some milk of magnesia. Like, no one cares about that. That's normal. That's human condition stuff. But these patients, it is just it's an all the time event, a very vexing all the time event. So that usually clues me in to, yeah, they may actually need my services and not just some diet advice, which I do offer the diet advice. But
But so you're not supposed to feel that way. You're not supposed to have that
no,
constipation. You're not supposed to have constipation at the age of
well,
25. It's just not a something's going
yeah,
on.
You should not have to strike six different yoga poses on the toilet to empty your rectum, right? You should not have to use manual assist to make all the body parts hold still so you can put that should not happen. And so, if that is happening as a general rule, that's someone who probably needs intervention. It can be confusing, I will admit, because the pelvic floor contains three different organs basically in women. So you can have a bladder, a vagina, a rectum. And oddly, there are three different doctors oftentimes that are involved in the repair, unless you've got a subspecialist like a gynecologist who's done a fellowship in urology or a urologist who's done a fellowship in gynecology. And I tend to operate more with the urologist, just we shared an office together. But as a general rule, if the front half of your body is falling out and you need a urogynecologist, a lot of times the back half is falling out, and oftentimes the back half is what caused the front half to fall out because of this chronic constipation issue. So I like to intervene on patients with constipation even at a young age, simply because the longer you have the crazy straining phenomenon, the more likely it is you're going to strain out your bladder and your vagina inside out with time. And at some point in time, you've destroyed everything, and it cannot be fixed.
Right.
Like only God can make this pelvis. Once you've made it that thin and stretched out the nerves and stretched out the muscles with all the hernias, it's just surgically a near impossibility to fix in a way that makes the patient happy because they feel like they have normal function. And that is the goal. So I like to intervene early. And a lot of these older doctors will let you complain of constipation for 30 or 40 years and just kind of ignore it.
Right.
Meanwhile, your pelvis is falling apart. So
Right.
so don't do that. If you've got any of those symptoms, seek help sooner rather than later. So
Right.
that's
And
my advice.
so what does a normal workup look like? What can these ladies expect when they come see you for you to
Right.
now build out how am I going to fix this young lady?
Problem. Yeah. So the first thing that I like to do, obviously, this is like a board exam now. So the first thing that you do, obviously, you have to meet the patient. Like, tell me what you mean by constipation. There are actually, and a lot of people don't know this, there are three different forms of constipation. One is you never have an urge to use the restroom. All right. So when I talk to the patients, I want to know, are you someone who poops once every 2 weeks and never your butt does not know you need to use the restroom. It's your belly that gives the cue. So in other words, you don't feel like you have to use the restroom.
Right.
That's one form of constipation that may actually not be related to your pelvic floor at all. The second form of constipation would be you strain really, really hard to use the restroom. And no matter how hard you strain, you just cannot empty your rectum. The vexing problem to have. And then the third form of constipation is actually a stool consistency.
Okay.
Little bricks are going through there.
Right.
So you do kind of have to know, like, what are we talking about here? Little bricks, that's not a surgical problem.
Okay.
This really slow constipation transit sometimes turns into a surgical problem, but a lot of times you can medicate your way out of it. That's what this Trulance and Linzess, that's the type of constipation that those medicines were designed for. It's the gymnastics on the toilet to empty your rectum. That's not a Linzess Trulance problem. And I know primary care doctors and gastroenterologists are giving that medicine for that type of constipation. And it's probably not the best approach. It's not, I'm not going to fault anybody for trying that, but a lot of times that won't help. Some of these people can't pass gas without the crazy gymnastics. It really can be quite a vexing problem. So when patients have that blockage from the rectum, obviously the first thing that I need to do is let me look at your butt and prove you don't have a cancer sitting there or a scarred down area. Some of these women have had babies and episiotomies. Some of these people have had hemorrhoid surgeries. You kind of have to make sure there's no scar tissue. The hole is kind of normal.
Right.
I usually start looking for things like how strong are the muscles, how good is the tone, do they have a vaginal bulge, are any other organs falling out of any other places, you
Yeah.
know. I may or may not look. Do you have hemorrhoids? Some people with hemorrhoids will have similar complaints. Almost everyone with this form of constipation has hemorrhoids. So a lot of these patients will come in with a hemorrhoid
Right.
complaint. They're not willing to tell people they got the constipation thing. They'll tell me they have hemorrhoids. And then I'll look and say, well, you got a lot more brewing back here than just hemorrhoids. Good great.
Right.
There's no
That's
muscle
the
tone anymore. You got
that's the
bulging all different
byproduct
kinds.
of you straining
Right.
for 20 years.
Yes, exactly. Now, every now and then, someone does have just horrific hemorrhoids, and they won't give me the history of constipation. I'll ask them if they have constipation. They'll say nothing. They're like Schultze on Hogan's Heroes. Does your audience remember them? So like I know nothing. So like they won't tell me they got this training. I'll take them to the operating room for the hemorrhoids. In the process of fixing the hemorrhoids, holy smokes! Like this person's got an internal rectal prolapse,
Right.
which is the surgical condition that I'm looking for in these patients with their blockage scenario.
So how would Dr.
And so,
Toker
yes.
describe a hemorrhoid? What's the? Could, you know, we could
So,
medically
so the
describe
patient
them.
will have so the issue is so like a patient with an internal rectal prolapse. That's the blockage. That's what you and I are actually talking about. Your audience doesn't know that yet. When someone has a rectum that wants to turn inside, it twists and turns inside out because of a series of hernias in the pelvis. Those patients strain. That is above the hem. You can't see that in the office. There's no exam in the office that says, oh my gosh, this is an internal prolapse. An external prolapse, I can see. Everyone can see. When the rectum finally succeeds, and it will, turning all the way inside out, it's obvious to the world. Once that happens, that becomes hard to keep it from rehappening after surgery. This is one of the reasons why I'm like, look, you got the hemorrhoids and the constipation. Let me see. Let me make sure you don't have this one other condition. Fix it now while it's simple to fix before it becomes a problem that every time I fix it, it's just going to come back in 6 months. You know, so that's what I'm hoping to accomplish. So anyway, on exam, I will see actual hemorrhoids, or I will see everything kind of looks normal except weak muscles. They'll have you can almost see the hernias and bulging of the pelvis. They have this what we call rocker bottom defect, where the pelvis kind of has this little rocker. These patients will also come in complaining of pain, heaviness, fullness. You've never been pregnant, Rob, but your audience will know. You know when you're pregnant, it feels like there's a bowling ball in your. Who put the bowling ball in my body? Like I didn't expect that when I was pregnant with my first child. Like what is that sensation? It doesn't occur to you when you're young that yeah, a baby weighs some weight. There's some weight there, and your body can feel it. So when your muscles are weak, all of your internal organs are trying to follow gravity. That's weight, and the weaker the muscles are, the more discomfort that causes. So some of those patients will come in, no hemorrhoid complaints, no straining constipation complaints. They'll come in with, I've just got this pelvic pain, this pressure pain. So all of those are kind of constellation of symptoms that I find when I see that anatomy. The one test that can find that with definitive certainty is an X-ray. It's hard to find this X-ray. Not all doctors even know this X-ray exists. It's called a defecography. That sounds terrible. It's called a defecography. It's an X-ray of you pooping. That's right. I said it. It doesn't hurt, but it's weird. Okay, and I apologize to everyone before I send them for the X-ray. This is the weirdest thing anyone's ever done to you. Okay, just want you to know because you're going to be awake and it's going to be odd. Okay, so this is the X-ray. Should I tell people the? I might as well educate them.
Yeah.
This is the
That's
X-ray.
why we're here.
All right, I'm gonna tell you. This I'm gonna pretend you're my pet. This is us in the office. This is how I talk. Okay, so this is the X-ray. So first of all, before you show up for the X-ray, you got to drink a bunch of laxatives to clean out your colon, like a bowel prep.
But
Right? You
but just
basically
not
take
there yet.
yeah. So right. So you what they do is they take a lot of Miralax. Okay, so I make them take Miralax, take a bottle of Miralax, mix it into 2 liters of Gatorade or lemonade or iced tea or something like that, and drink the entire thing
Sounds
until
delicious.
it's yummy. It's yummy. You drink it, And then if what's coming out of your bottom at the end of all that does not yet look like apple juice, you repeat. Okay. And just that purges the system so the x-ray doesn't get confused by poop. All right. So there's a plain x-ray. You cannot tell the tissue, the difference between tissue and poop. That's the problem with x-rays. Okay. So when you show up for the radiology department, they will make you drink some barium, which I hate because constipated patients don't do well with barium. Then they will take a tampon, they'll soak it in a barium like solution, stick that vaginally so they can see where the lining of the vagina is. And then they'll squirt what is almost like a oatmeal consistency x ray contrast into your rectum with a caulk gun. I know I'm selling it. I'm selling your audience right now. They're like, that sounds awesome. So they fill this stuff in your rectum. Then they put you on a toilet, and then they surround you with x-ray machines. And this is in a giant room. I mean, you're like in this big old room. There's text doing all this stuff to you, and then there's a radiologist talking to you in the booth, telling you, to cough, to sneeze, that he's looking for incontinence, right? And then pinch like you're holding it because he's looking for the do the muscles move, and then he'll make you poop out what's in the rectum,
So
so he can see
what's the
all
tampon
the different
doing?
bulges. It's outlining the vagina. That's all it's doing. So he can see where the vagina is. Because
Ah,
he wants to know when he sees a bulge, how much does that impede upon the vagina as a rectocele? He also wants to be able to tell the difference between small intestines crushing down on the vagina versus the rectum crushing down on the vagina. So you can't really see the bladder during this phenomenon, but you can see the small intestines, the vagina, the rectum. So all three of those things have to have contrast in them so he can see where everything's going. So some patients will have muscles that are so weak, which is why they can't use the restroom. They don't have this prolapse phenomenon, but they have very, very weak muscles. Some people will have an odd herniation through the top of, if they've had a hysterectomy in particular, through the top of the vagina where the small bowel crushes into the vagina and pinches off the rectum. So that can cause constipation. Uh, and then some people will have just the big rectocele that can't empty. And then what I am looking for is the rectum itself can fold in half and start trying to fall out. So all of those different conditions have different treatment approaches. So weak muscle only, we do physical therapy. Physical therapy that I send my patients to is in my office because it's not embarrassing. It's a chair you sit on that runs the magnet, and the magnet makes the muscles contract. It's called an M-Cella chair.
love that chair.
Um, yeah, oh,
Did
it's
have?
amazing. No, it's well, and what I find fascinating that I love my M-Cella chair. I will go to my grave. So you cannot take my M-Cella chair. If I go bankrupt, I will not let them repossess my M-Cella chair.
Uh,
I love it. It is so therapeutic. It's so awesome. I do bill patients for that as a doctor's office visit, and that is not the same reimbursement as if I were to bill cash. But honestly, I don't care. These are little old ladies on Medicare. They're not going to be able to afford $200 a session
right.
to sit on the little electric chair. So I just bill them a doctor's visit. I'm like, look, if you don't mind talking to me, instead of sitting on an exam table talking to me, I'm going to sit you on this fancy electric chair talking to you, and we're going to call it a day. That is how we do physical therapy in my office. So that's the weak muscle people.
Okay.
Now, some of my patients that have weak muscles also obviously have the prolapse. And so I'll make them do the physical therapy before we do surgery. And then when they've healed from surgery, I make them get back on the physical therapy because our surgery can't build muscle.
Right.
I can stop the blockage. I can use artificial materials to tack things up so that they don't slip. And then, of course, I use a biologic material to reinforce, and then that's how you and I met, but to reinforce the front and back of the rectum so that your body at least can kind of give some of that soft tissue a little bit more firmness. But so you can't rebuild muscle. That's the purpose of the physical therapy. All right, so a rectal prolapse I fix with surgery. There's two different types of surgery. The rectocele, I actually don't fix rectoceles. I do that in combination with a urogynecologist or this gyno-urologist. I mean, with a
Right.
specialist who does that pelvic floor repair.
Right.
We're often in the operating room at the same time doing these things because she will also fix the bladder if that needs to happen, or tack the top of the vagina up to the backbone if everything is falling down. It is definitely a complex issue. In my opinion, it's almost never only one doctor's opinion. There are some doctors who won't refer out for other opinions. And interestingly, there are some urogynecologists that don't do the defecography, which I think is a technical mistake on their behalf, but it may be because they don't have a colorectal surgeon to work with. Why ask a question if you don't have the answer?
Right.
In my opinion, I think everyone gets defecography. You may not be able to operate with your colorectal surgeon. Do your part, send the patient over to the colorectal surgeon who can then finish it. Because if you don't get rid of this outlet obstruction constipation, your problem is coming back. So it all has to be addressed at the same time. It's a very complex
So why
issue.
do they? Is it a pregnancy thing? Is it why do they have? In essence, you've got this colon that is not straight, right? So
Yeah, yeah,
and you have to go in there and try to either
straight up.
remove some of it, right? So
Yeah,
you do remove some
yes,
of it, or
part of the,
you straighten it out, right? We want to.
we get our iron out. We just iron it out.
Hey, listen, we need that thing to be
Suspenders,
right.
belt suspenders.
We need a straight shot.
We need a straight shot. So there's a couple of reasons why this happens, and there are some people who have never had children. I've got young patients who've never been pregnant who have this problem. So there are some people with collagen disorders. They don't make scar tissue. They have very lax ligaments. And of course, the entire pelvic structure in women is held up with ligamentous structures,
Right.
ligaments and soft tissue. Men don't have this problem. Their pelvis is very narrow. They've got a prostate that's blocking that hole like a little cork. So guys don't really develop this problem unless they're lifting extremely heavy weights. It's very rare for me to have this problem in a male patient. Now, women, on the other hand, huge open pelvis. A baby's head's got to go through there. And a young person will have muscle, they'll have fat, et cetera, et cetera. As we age, just like everywhere else, things just kind of, you lose musculature, you lose tone.
Right.
And so now you've got all this musculature and tone that's been filling the pelvis and holding everything at bay, and that disappears. And so it becomes a deep bowl, like a spaghetti bowl. And you've got, imagine this weight like a uterus kind of just flopped in the middle of this bowl. Now it sinks to the bottom of the bowl. And the colon is not a rigid structure, it's a flexible structure, like a piece of spaghetti. So that thing will just kind of like, you put one piece of spaghetti in the bowl, you'll see it just kind of go to the bottom of the bowl and wind up into a little coil. So that's kind of what's happening. So the probably the best model to think of is if you had a bowl of water and you put a straw in it, or no, a string. Let's use a string. Put a string in it. You freeze the bowl so that the string is upright. Let that bowl sit out for some time. As the water melts, the string folds and bends. Next thing you know, all the water's melted. The string's at the bottom in a coiled up mess. Like we all know what that vision would look like.
Yep.
That is what's happening in the pelvis. And I cannot fill that space with anything. All I can do is unwrap the coil of intestines or colon, lift the rectum up in an upright position because it'll fall and kind of get sideways, you know. And that sideways orientation with a little bit of hernia into the vagina allows for the thing to turn inside out, like the cuff of your pants. It's like rolling up your pants. That's sort of what happens. And so we want to straighten up that rectum straight up and down.
Yep.
We tack it in place. There's a little hernia behind the rectum, little hernia in front of the rectum. We patch that with this biologic material. And then if you've got a huge loop of colon, that's a big floppy loop of colon, a lot of times we'll remove that and hook everything back together. There are some people we catch early enough where they don't have the big loop. They just have kind of the fallen rectum.
Yep.
That's pretty easy. We just lift and tack. We don't have to remove anything. And there are even some people who have never had a hysterectomy. They're young enough. Their only complaint is this blockage. On the X-ray, there's not much motion. It's super early, and that I can get through the bottom like a glorified hemorrhoid procedure.
Okay.
There are some older patient. Okay, I have an entire herd of cows looking at me right now. Just want you to know. They're staring at me. It took my eye. Anyway, so
They're watching the
they're
podcast.
they are watching. They want to know. They're all heifers. They have their babies out there. Like, no, that could happen to me. Yeah, it could. Totally could. Anyway, and there are some patients who are older that that complex abdominal surgery is too much for some of these little old ladies.
Right.
We do that through the rectum as well. Just accepting that it may not be quite as definitive. They may have a recurrence in the future. So that's kind of my approach on what I'm thinking. Does that make sense?
Yeah. So I think about all the things that you do, and I would love to avoid it.
Yes.
Right. I
It's
think
on
I
the
think I
anti-bucket
think you
list.
have you are definitely booked months and months and months in
Yeah.
advance with no shortage of patients. But if I'm a
No.
patient,
No, we are booked out months and
if
months.
I'm a
Yes.
patient,
Mm-hmm.
I'm a female,
Mm-hmm.
between 20 and 75, right?
Sure. Yeah.
So how do I, lifestyle wise, how do I
Mm-hmm.
avoid these things happening? Right? So how do,
Okay.
what do I need to do? How should I live my life so that I have a nice, as possible, nice straight colon? I go regularly. Is it
Yes.
probiotics? What is it? What's the formula that you
Yes.
recommend for people?
Okay, yes. So the first thing that I would tell people to do, especially if you've had children, are the Kegel exercises. A lot of people think of Kegels as just being a bladder issue. But when you squeeze those muscles for a Kegel exercise, you're squeezing the entire levator floor. You're lifting that like an elevator. You want to lift that levator floor to give it strength. Strength in that levator floor goes a long way. So does abdominal core musculature. So, just from an athletic standpoint, doing planks and Kegels, Kegel and core. I can't say enough about Kegel and core. If you want to avoid this particular condition I'm describing, it involves core and Kegel exercises. And if you cannot do them themselves, you've either got time or you got money because there are machines that will do that work for you. I own a med spa. We have those machines,
Right.
right? I mean, go into your local med spa and have them slap an M sculpt on you, on your belly, sit on the M chair. It does it for you. I've got some older, I have an old M sculpt, the older technology. I've got a new one and I've got an old one. My older one, the patient's paying cash. They don't want the older one because it's not as effective as the newer one. So that older one I actually use on my little old ladies whose rectums are falling out, their vaginas falling out, they've had multiple surgeries, their bellies are soft as kittens, their bottoms are rocker bottom horrible defects. And I just, you know what? This is a Christian mission at this point in time. We're going to use, no, you're not going to pay me any cash. I bill insurance for it. I take a loss. I don't care. It's little old ladies. And it helps immensely for their back pain and for their bowel habits. So Kegels and core, I can't stress enough.
So what
Start
about diet?
when you work out. Yeah, and then diet, right? So diet, this is important. So fiber, and a lot of people think of fiber as being like bran, or eating a salad. And those things do have some fiber in them. So veggies have some fiber in them, and bran has some fiber in them. But what you really want if you have a constipation issue is a soluble fiber. So fruit fiber tends to work better. And the best fruit actually is kiwi fruit. So if you're not allergic to kiwi fruit, 2 kiwi fruit a day, very helpful.
Okay.
Prunes, grandma, your mother, your grandma, they were right. Prunes are good. Dried apricots, dried dates. So dried fruit
Okay.
has a lot of soluble fiber, and soluble fiber is part of what the colon needs. The other thing your colon needs is to drink a lot of water. A lot of people, especially I'm in Texas, a lot of people are drinking iced tea, and it's sweet tea.
Right.
So they drink the fluid and they pee it out. They don't realize how dehydrating caffeine is. So you want to be nicely. hydrated. If you want to flavor your water, just make it non-caffeinated, please. I prefer not using any artificial sweeteners. Flavor stuff with honey if you can,
Okay.
or monk fruit or stevia, because those things are natural, and natural things don't kill off your intestinal tract bacteria. So some patients with GI tract problems, the real problem is they've got the wrong mixture of bacteria in their intestinal tract. And while I do suggest a probiotic, taking one strain of lactobacillus is not going to solve all of your problems. It's helpful, but the way to get diversity in your intestinal tract is to eat as much diverse fruits and veggies as you can in their raw state. I mean, you wash them off, but you can't sterilize the skin. You need the skin. That's where the bacteria live. So every single organism on the planet is coated in bacteria, and you, human being, are supposed to be consuming that. That actually belongs. The good bacteria belong in your intestinal tract, right? Don't cook everything. Don't sterilize everything with bleach and all kinds of the antimicrobial. You need some of that for diversity. And once you've lost the diversity, your belly gets upset, you get IBS type stuff, diarrhea, constipation, those kind of things. You also will gain weight. You can also get anxiety, depression. A lot of these patients with this condition are already like, they're already anxious. And you can imagine if you got to poop and you can't poop, you know what that would do to you. You kind of would be like, nah. But the colon and the intestinal tract is also responsible for making serotonin, dopamine, epinephrine, norepinephrine, all of the neurotransmitters in your brain that control your personality and your mood. Those are all made by the intestinal tract bacteria. So you want diversity there. So all right, so we got fiber. We talked about probiotics. We talked about exercise. We talked about water. Behaviorally, I would avoid prolonged reading while sitting on the toilet, squat exercise, do lunges instead, or do like Stairmaster instead. Because the longer you spend sort of in that squatting orientation and straining, the more you're encouraging stuff to try to fall out of your
Right.
pelvis. And as you get old, it's good to exercise. Muscle mass is so important as we get older. But I would encourage people to do lunges instead of squats, if that makes any sense.
Definitely.
Okay, what else? Did I miss something? I don't know. What else?
I don't think you missed anything. I think that we definitely learned a lot on our
Too much.
program
Oh,
today.
I'm sorry. It's diarrhea. I can help myself. I just keep talking.
So the best part is that we get to have you back.
Of course. Oh
So
my gosh.
so
Yes.
so that's first and foremost. If people want to see some of your videos, I know you have
Yes.
your website,
Yes.
Dr. Toker MD. Is it drtoker.com?
So yeah, it's drtoker.com, and I am actually, not that you care, but I am switching over my website from one provider to another because they were mean to me. So I am switching companies, just so you know. But I'm going to keep the same website URL. It's drtoker.com.
Perfect, perfect. And we've got we
And so some of our videos that I have on YouTube are actually in my med spa. So our med spa is Scandi Med Spa. So you can YouTube search those words, SKANDII Med Spa. And so a lot of the videos there that are about diet, nutrition, are there for,
probiotics.
yes, probiotics,
you're kind of
because for the meds, yes. And then for Instagram, as you know, Rob, you were my inspiration
thank you.
for putting videos on my Instagram. And and in fact, Rob, I just have to say, helped me come up with the name for our Instagram, which is the Ask underscore Dr. Pooper Fixer. And that is our Instagram exchange.
There you go. I love it. I love it. Well, listen, uh, we are going to definitely have you back. We're going to post all of those websites. I've got Dr. Duncan who's joining us.
Oh, okay, goody.
Isn't that nice of him? I love that. We're just like
I was
back to.
wondering, I was like,
We are back
I'm
to back
staring at a
today.
face.
We're
I was
back to
like,
back
I,
today. So
oh, okay. I was going to say, I'm looking at someone who seems very nice. I don't know who he is, but whatever.
he's
Hi,
out and
Dr. Duncan.
there you
Yeah.
go, Dr. Duncan, Dr. Toker. We're gonna have you on the show at the same time, and
Oh, that'd be fun.
and
Okay,
maybe
great.
Dr.
Let's do it.
Zananti. We're gonna have him back on,
Oh, my God.
right? So
So
that'll be a very interesting conversation.
that'd, that'd be an amazing
That will
conversation, I
be
think.
that'll be nonstop entertainment.
Nonstop.
I just
All right, sir.
so
You
listen.
can ask me back anytime and ask me almost any question.
I love it. I love it. Listen, you have a wonderful weekend. Thanks for
You too.
joining us today.
My, I'm
We
so sorry I
appreciate
ran.
it. Now,
Yep.
all good. We learned a lot, and now we're just gonna put some of it into practice. I'm gonna go find some fruit.
Kiwi.
That's right. I'm gonna
Kiwi
find some
fruit.
kiwi.
Kegel's Core Kiwi. It's easy. It's an easy formula.
All K's.
Okay. Well, kind of.
I
You
love
can
it.
make them all K's.
I know, right? Right. Three
All right.
K's.
Yep. Yes.
All right.
All
Beautiful.
right.
Dr. Choker, thank
Talk to
you.
you soon.
All right.